Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about intrauterine insemination. So, what we want to discuss today? The definition of IUI, the clinical use, and the recommendation. Okay, what is the definition of intrauterine insemination? This is a procedure in which processed and concentrated motile sperm are placed directly into the uterine cavity. As you see in this picture, this is the uterus and this is the syringe containing sperm, and this is the catheter inserted inside the uterine cavity. The sperm is injected inside the uterine cavity at the time of ovulation. Okay, so this is simply the intrauterine insemination and was first described by Cohen 1962. So what about the clinical use? Clinical use of IUI is based on the hypothesis that if you place large number of sperm high in the reproductive tract, this enhances the likelihood of conception. Okay, the minimum requirements for performing the procedure are: first, I need ovulation. Yes, I need at least one patent fallopian tube, because if there is bilateral blocked fallopian tube, there is no rule for IUI. So to use IUI, intrauterine insemination, there must be at least one patent fallopian tube and the ovulation from the same side of the patent fallopian tube. Okay? Okay. What else needed as a minimum requirement? Adequate number of motile sperm and absence of documented or suspected active cervical or intrauterine or pelvic infection. Okay, there must be no pelvic infection or cervical or intrauterine infection. Okay, this is the minimum required. Okay, IUI is particularly useful in couples with some types of severe sexual dysfunction. Like what? Like severe vaginismus, like premature ejaculation. Okay, or any ejaculatory dysfunction, or discordant for sexually transmitted disease carriage. Give me example like HIV or hepatitis. Okay, okay. For cervical factor or mild male factor infertility, IUI allows sperm to bypass potentially hostile cervical factors, thus increasing the number of sperms that gain access to the uterine cavity. Okay, if you are suspecting that this cervical mucus is hostile to the sperm, then by the use of IUI you are bypassing this hostile cervix. Okay, okay. What else? For women undergoing ovulation induction, including those with unexplained infertility or minimal or mild endometriosis, it was found that pregnancy rates are thought to be higher when IUI is used with ovarian stimulation instead of using timed natural intercourse. So if in cases of unexplained infertility or minimal endometriosis you used the IUI with ovarian stimulation, it is suspected to have a pregnancy rate better than if you are using timed natural intercourse. Okay, okay. So let us go to the recommendations, and please concentrate very well, because I put it here in the lecture in questions, and this is the core of our lecture today, and guided by the human reproduction update published. The article was published in about 2018. Okay, so First question, what are the indications for IUI versus intercourse or expectant management in infertile couples, and when should treatment be initiated? Okay. In couples with unexplained infertility with a prognosis of becoming pregnant without assistance within the next 12 months, estimated more than 30%, IUI could be postponed for at least 6 months. So, if we have a couple with unexplained infertility and the prognosis of becoming pregnant without assistance within the next 12 months estimate more than 30%, you can wait at least 6 months for natural process, intercourse, and so on without IUI. Okay? Okay. So don't be hurry. Okay, what are the indication for IUI versus intercourse or expectant management in infertile couple, and when should treatment be initiated? The same question as before, but here there is a difference. In couple with unexplained infertility and the men with a total motile sperm count more than 10 million and the prognosis of a spontaneous pregnancy less than 30% within a year, it is recommended that IUI plus ovarian stimulation is the treatment of first choice. So there is difference between this and the previous slide. Here the prognosis of spontaneous pregnancy is less than 30%. Okay? So I should start with IUI plus ovarian stimulation. Okay? Okay. Next, same question. What are the indications for IUI versus intercourse or expectant management in infertile couples, and when should treatment initiated? In couples with solely a poor sperm quality in the male partner, it is not recommended either for or against use of IUI. So we cannot say use it or not. There is no recommendation for this point. Okay, in case there is poor sperm quality. Okay, when ovarian stimulation required in an IUI cycle, when to use ovarian stimulation? In couples with unexplained infertility and the men with total motile sperm count above 10 million, IUI should be combined with ovarian stimulation to improve live birth rate. Okay? Okay. What is the influence of sperm quality on an IUI outcome? Another question, can we define threshold levels for successful IUI? Okay. It is not possible to define clear lower cutoff level of pre or post wash sperm parameters below which IUI should be withheld. Same question. Providers can determine the method of triggering in IUI stimulated with gonadotrophins, as there is no evidence to recommend for or against a method. Providers can determine the method of timing IUI in natural cycle without ovarian stimulation, as there is no evidence to recommend for or against a method. Okay, if HCG injection is used for triggering ovulation, okay, single IUI can be performed anytime between 24 and 40 hours after HCG injection without compromising pregnancy rate. So, if you are using HCG for ovulation, okay, you can do one IUI within 24 to 40 hours. Okay? What about the natural cycle with IUI? IUI in natural cycle should be performed 1 day after LH rise. So, you do screen for LH. After LH rise, you will do IUI after 1 day from the rise of LH. Okay? What is the value of fallopian sperm perfusion compared to IUI? Is it better than IUI? When I insert the catheter inside the uterus, I can insert a cannula to the tube and insert the semen, the sperms inside the fallopian tube. This is called fallopian sperm perfusion. Is it more valuable than intrauterine insemination? The intervention fallopian sperm perfusion when compared to IUI shouldn't be treatment of choice. Shouldn't be the treatment of choice. So use IUI, intrauterine insemination, and not fallopian sperm perfusion. What is the optimal number of insemination per cycle? How many numbers of IUI I can do in the same cycle? In both unexplained and the male infertility, there is insufficient evidence that the intervention double IUI within the same cycle will lead to better pregnancy rate than a single IUI within a cycle. So there is no evidence that if I did it twice IUI in the same cycle, the results like pregnancy rate will be better than if I did IUI once per cycle. Okay, so use it one per cycle. Women, is there a benefit of bed rest after IUI? Is there a benefit of bed rest after IUI? Very common question. Okay, many gynecologists ask for bedridden for 1 day, 2 days or more. No, it is not needed. Women undergoing IUI should have 10 to 15 minutes of bed rest after an insemination. 10 to 15 minutes of bed rest after an insemination. What is the ultimate number of consecutive IUI cycles per couple in which pregnancy rate still increase significantly? How many number you should do IUI repeatedly? Consecutive. Okay? In couple with an indication for IUI, at least 3 consecutive IUI cycles should be performed. So do it for 3 cycles, consecutive cycles. Okay? When it is indicated. Okay? There is insufficient evidence to recommend a maximum number of IUI treatment cycles. So when indicated, the minimum is 3 cycles. Is there any maximum for IUI treatment cycle? There is no evidence about that. Okay. Next, which semen preparation technique used yields the best results? I mean by the word results, pregnancy rate for IUI. Okay? According to the available evidence, it is not possible to recommend any semen preparation technique over the other. Okay? Like swim up, like wash and centrifugation, like gradient, and so on. What is the cost effectiveness of IUI versus IVF and ICSI? And here we mean by cost effectiveness the use of resources in healthcare system and the result, which is occurrence of pregnancy. Okay? In couples with unexplained infertility and the men with total motile sperm count of more than 10 million and the prognosis of pregnancy without assistance less than 30% within a year, at least 3 cycles of IUI with ovarian stimulation is the most effective option. We mean with the most effective option with using less resources and less cost, and may give a good result. Okay? So please remember that in many countries the fertility management and assisted reproduction is not included in health insurance, and it will be costly for the couple. Okay? How can you prevent infections in an IUI laboratory? Good practice points. Couples and individuals undergoing IUI and the males providing semen sample for IUI should be screened for infectious agents based on local, regional, and the national standards and regulation. Of course, we will search for sexually transmitted disease, HIV, and so on. How can you prevent multiple pregnancies and ovarian hyperstimulation syndrome in an IUI program? This is an important question. In order to prevent high rate of multiple gestation pregnancy in IUI with ovarian stimulation, IUI should be withheld. Stop it when more than 2 dominant follicles more than 15 millimeter, or more than 5 follicles more than 10 millimeter at the time of HCG injection or LH surge are present. Okay? So, if you are planning to do IUI and you give stimulation, ovarian stimulation to the patient, and you found more than 2 dominant follicle more than 15 millimeter, or more than 5 follicle more than 10 millimeter at the time of HCG injection or LH surge, please stop, don't continue, withhold the IUI. Okay? When gonadotropin are used in IUI, regimen with 75 international unit or lower should be used. Why? Because higher dose have similar pregnancy rate but increase multiple pregnancy, and we know the complication of multiple pregnancy, and also may cause hyperstimulation. So we are using soft regimen. We are using 75 or lower international unit of gonadotropin. Okay? Or when we use clomiphene citrate or tamoxifen, which will be acceptable alternatives to low dose gonadotropins, will lead to low multiple pregnancy and birth rate and with lesser costs, although at a lower level birth rate than with gonadotropins. Okay, addition of GnRH agonist to gonadotropins in IUI with ovarian stimulation is not recommended. Why? Because there is no increase in pregnancy rate despite increased multiple pregnancy rate and increased cost. So why to use it if it will cause multiple pregnancy with its complication, if it will increase the cost, and at the same time there is no increase in pregnancy rate than others. So why I'm using GnRH agonist in addition to gonadotropin? So please don't add GnRH to gonadotropin in case you are doing intrauterine insemination with ovarian stimulation. Okay, good practice point. As an alternative to cycle cancellation, aspiration of excess follicles at the time of HCG injection or LH surge might be additional option for reducing the risk of multiple pregnancy in IUI with ovarian stimulation. This is a good practice point. Okay, if there is more than two dominant follicle more than 15 millimeter and you are afraid from ovarian hyperstimulation, the multiple pregnancy and so on, we said before, withheld the IUI because of this. Or if you have more than 5 follicle more than 10 millimeter, withheld IUI because you are afraid from the multiple pregnancy and ovarian hyperstimulation. But there is another solution, is to aspirate the excess follicle at the time of HCG injection or LH surge to reduce the risk of multiple pregnancy. Okay, this is an option. Is there a different perinatal outcome for IUI pregnancy, and how does this perinatal outcome differ from normal coitus pregnancies? There is difference? Yes, there is difference than the normal coitus pregnancies. It was found that there is susceptibility to preterm birth and low birth weight in singleton and in twin pregnancies when compared to pregnancies in fertile couple not requiring assistance. So you should know about this. Please look to this article, IUI Review and Systematic Assessment of the Evidence that Support Global Recommendation, published in Human Reproduction Update in 2018, and many recommendations in this lecture guided from this article, so you can read it. Thank you. Please remember my 4 books published on Amazon: Textbook of Obstetrics, Textbook of Gynecology, Contraception Handbook, and Multiple Choice Question. And this is my site on Amazon. Thank you.